Thank you, Duncan. Thanks for having me here today. I'm going to be, I think, taking a little bit of a different approach from the previous speakers because I'm going to be bringing you very new research, very early days of our research project. We've just gotten started on this work, so I won't have quite as finalized slides on some of this content. And what I'd like to talk about is the value of thinking from a system-based approach or thinking about responding to the needs of frail older people at the system level rather than a sector-by-sector level. If you think about complicated populations, so frail older people would be one example, people with mental illness, people who are dying, in all those cases, those are people that you see throughout the health system. You don't just see frail older people in nursing homes, you don't just see people with mental illness in psychiatric hospitals, and people don't just die in hospices. It happens across the system. So a system-based approach probably does make a good deal of sense if we're thinking about how do we identify and respond to frailty. So I'm here presenting on behalf of our auspicious team. Paul Hebert is our co-lead on our project, and we have a number of different collaborators on our team and great industry partners working with us. So what I'd like to do today is to tell you a bit about the use of inter-eye assessment instruments in Canada, assuming that not all of you are familiar with these instruments, and it's worth giving a little bit of a background on that. And also to tell you about our TVN study objectives to say how they relate to this idea of working at a system level and thinking about how to get the system working together. And then finally, some tantalizingly early results that maybe sort of will tweak your interest in the kind of work that we're going to be pursuing. So first of all, if you're not familiar with Inter-Eye, what we are is we're a not-for-profit network of 95 researchers from 35 countries. So the backgrounds of the Inter-Eye network, about half are physicians, half are PhD researchers from a variety of different backgrounds. The physicians tend to be a mixture of geriatricians, internal medicine, and psychiatry, and the PhDs come from a huge range of different disciplines, from economists and mathematicians to social scientists and epidemiologists. And what we're interested in doing is developing comprehensive assessment tools to address the strengths and preferences needs of complex populations. We're not interested in people with very simple needs that can be addressed without the need for assessment. We're really interested in these complicated populations like I described earlier, frail older people, people with mental illness, people who are dying, and increasingly also young children with complex needs. And the way we do this is through an ongoing program of multinational collaborative research. We work together a lot to create these instruments, but we're particularly interested not just in creating forums that can be used to gather data, but thinking about how those instruments can be used to inform decision-making by clinicians at the person level and by managers and policymakers at the population level. So these are the countries that are involved in the Inter-Eye network so far. If it's got a blue text there, that means that there's a formal fellow representing that country. Green text are countries where we don't yet have a formal member, but we're collaborating with individuals in those countries. So as Duncan said, there's now 35 countries in the Inter-Eye network. There's about 14 Canadian members of the Inter-Eye network, and we cover pretty much every continent now. We haven't done anything in Antarctica yet, but there may be some penguin research that we could get involved in. What's exciting about being involved in a network like this is the opportunity for natural policy experiments. When we have comparable data between different jurisdictions, we can see how do different types of policies relate to different outcomes that you may see in terms of approaches to care for frail older people. But also you've got the opportunity to look at things in very different ways. There's very different models of service delivery, different population age structures, different approaches to how healthcare is funded, and that helps to sort of diversify the range of ideas that you're looking at and the kinds of questions that you can test. This is the current range of inter-eye assessment instruments that we have available. So we have both adult and pediatric home care assessment instruments. The contact assessment is an instrument for intake into home care services. We have a nursing home instrument that in Ontario is also used in complex continuing care hospital settings. I'll talk more in a few minutes about our new acute care instruments, both for the emergency department and for acute hospital settings. A palliative care instrument that can be used with adults of all ages in community or residential-based palliative care programs. The community health assessment instrument is designed to be a modular assessment instrument that can be used in a more heterogeneous population, say in supportive housing, where you'll see folks that are fairly independent on the one hand and other folks who are more complex, with a modular style that lets you ramp up the depth of the assessment being used depending on the person's needs. I'm very heavily involved in our mental health research. We have a very large family of mental health instruments covering inpatient psychiatry, community-based mental health services. We've got a new screening tool that police officers can use to screen mentally ill people that they apprehend in the community, and a new suite of children's mental health instruments as well. And then an assessment instrument for adults with intellectual disabilities that was used in Ontario for closing the last 4 large institutions and moving people to residential settings. We also have a new family of subjective quality of life instruments. So we have a big suite of comprehensive standardized assessment instruments that are assessor administered, but we have new quality of life instruments that are rated from the person's perspective. They're more survey style instruments asking about their experience in different care settings. It's useful to think about, well, if we were to call this an integrated health information system, what is it about it that makes it an integrated system? First of all, it's got a common language across all of these instruments. That there's a standardized terminology that we use for what we call the same thing in different care settings. And there's a common emphasis on embedding items that would trigger care planning activities. We don't just gather data for the sake of gathering data to make a gerontologist or a geriatrician happy for research purposes. It's got to trigger a clinical activity in the form of a care planning approach. And the emphasis is on function rather than diagnosis alone. Yes, we gather diagnostic information. It's important to have that. But it turns out that function and measures that relate to frailty are much more important in understanding what happens to the person than just diagnosis alone. And he uses a common approach for data collection. So the approach is always to have the assessor use their professional skills in engaging the person, getting information from all sources of information. So you interview the person directly, you speak to family members, you use your own eyes and ears to observe what's happening. You may speak to other colleagues, and you may look at the chart, and then as the professional, you make the judgment about what's the most correct answer to record. And so a typical example that I would give is when my late father-in-law was living with us, the home care case manager came to our home to do a inter-eye home care assessment on my father-in-law. She was a little nervous when she realized who Fred Pearson was or who he was related to, but I sort of stayed out of the way. And so she was interviewing my father-in-law about asking him about bathing, and he said, "No problem, I can bathe by myself." But in the background was my wife waving frantically, saying, "No, no, no, he has a lot of difficulty." And so that's sort of a typical situation. You've got competing source of information, and as a professional, you've got to make the judgment about what the correct answer is, and that's the standard approach that we use in all of our instruments. We also have common core items that appear across all instruments. So all of our instruments have measures of cognition, basic measures of ADL function, of pain, of depressive symptoms, and so on. They're common standards across every instrument. We also have specialized items that only appear in certain instruments, but this common core is something that we use to describe all human beings, regardless of who's their service provider or what care setting they're in. And we have also a common set of care planning protocols for adjacent sectors of the healthcare system. So a common approach to care planning triggered from the home care instrument and the nursing home and the supportive housing instrument. We also have common care planning protocols for inpatient and community mental health services. So whenever we're thinking that it's a very comparable population and people are likely to be moving between the two sectors, we think about, can we ensure continuity of care planning in addition to continuity of measurement or continuity of assessment approaches when we're comparing people across these settings. So this is a schematic that I keep always updating to show the use of inter-eye assessment instruments in Canada. If it's a solid icon like that, it means that the government has mandated the use, or in one case in Nova Scotia, recommended the use of it, but in every other case where it's a solid icon, it means that the government has ultimately mandated the use of that assessment instrument. So the red dots are our nursing home instrument. which are now used in 9 provinces and territories, all at different stages of implementation. So that first dot in Ontario came in 1996 when complex continuing care implemented our nursing home instrument. And this red dot for New Brunswick is really literally today. They've just started implementing the new long-term care facility instrument in that province this year. So there's different stages of implementation happening. But for nursing homes, it's become a de facto national standard. In the home care sector, the blue squares are the same kind of thing. 8 provinces and territories have mandated the provincial use of the home care instrument. In Manitoba, it's only used in the Winnipeg Regional Health Authority, but there keep being plans talked about finally moving on a provincial level. Our mental health instruments are used, mandated in Ontario and in Newfoundland. The only freestanding psychiatric facility in Manitoba uses that as well, and we have our first pilot tests of intra-eye instruments in Quebec. And I did think that once Quebec started using intra-eye instruments, I could retire, but it's a bit early for that, so I've got to set a new standard. Now it's going to be PEI. They're the last holdout in terms of provinces for us. Our contact assessment is used mainly in Ontario, but a number of provinces are beginning to use it for intake. Our palliative care instrument is now used for all community-based palliative care in Ontario. The community health assessment is used for all community support services in Ontario, so this would be things like Meals and Wheels, seniors housing, independent living, and so on. And the Ontario Provincial Police have implemented our police screening for mental health apprehensions in the community. So a couple things. First, for at least 2 of these instruments, they have become the de facto national standard for assessment in those sectors. Last year, the Canada Health InfoWay declared these as Canadian approved standards for the electronic health record, which is an important milestone in terms of the health informatics world. But also, when jurisdictions start to implement one of these instruments, they start to implement multiple instruments because of the recognition of the value of the idea of having a common language, a common assessment approach, linking people across these different service settings. Oh, I should have mentioned also that now we're beginning to see movement on our quality of life instruments. So the newest kid on the block is British Columbia just announcing they're going to be implementing our quality of life survey tool for nursing homes across that province. And last week, Extendicare said that as a chain, they would start using our quality of life survey in their long-term care homes. So to give you a context of where we are, we work very closely with the Canadian Institute for Health Information, CIHI, who run 3 national reporting systems where all the intra-eye data go to nationally. So we're at 10 provinces having done research or mandated implementation. So CIHI's estimate, there's about 15,000 clinicians who've been trained to do intra-eye assessments out of about 19,000 organizations in Canada. And if we add it all up, in December of 2014, we were just under 8 million intra-eye assessments of over 1.5 million Canadians. And each year that number goes up at by about 600,000 assessments, and those data didn't include the first waves of Alberta data that have just started to become, begun to be submitted. So this is a very large-scale implementation that's happening in the country, covering many of the major sectors of the healthcare system, and these sectors just keep growing over time. So what our project is going to do is it's going to leverage some of those existing data and link those data to hospitalization data. And we're going to do some pilot testing of one of the newer instruments in a way that hasn't been done before yet in Canada. So one of the projects that I'll tell you a bit more about is we're interested in looking at what's the trajectory of change for people in nursing homes and home care settings in terms of mortality and a move toward hospitalization, and what factors are associated with a greater likelihood of decline along that trajectory. We're going to do lots of record linkage working with CIHI to bring these data together to be able to look at those types of trajectories. We're also interested to see what happens to people who were in ICU settings in terms of ending up in the nursing home and home care sector. We're really interested in seeing, can we link home care or nursing home assessments done before hospitalization to a hospitalization event, and then the assessment afterward to see how much functional loss or improvement happened after that event. We'll see what the feasibility of that. That's going to need pretty substantial numbers to be able to pull that off, but I think we're in a position, at least for the home care and nursing home sectors, we'll be able to do that. The trickiest thing is going to be getting a good quality measure of ICU exposure from the CIHI data. Paul is leading a systematic review of decision support tools being used in ICU to identify frailty and to inform decisions around care intensity and so on. But the last project that is a new primary data collection effort will be one to pilot test the new acute care set of instruments that INTRI has created. The INTRI Acute Care was something that we worked on as a group in the late 1990s and then moved on to other topics for a while. But our colleague Glenn Gray from University of Queensland has been very successful in doing research with the INTRI Acute Care in Australia, and so we felt that this was a good time to build on the knowledge that he's developed to try this out. And so our approach will be to use a very simple triage app that INTRI has created. It's available free on iPhones and Androids. If you want to just do a search for INTRI and ED Screener, you'll find the app. So we'll use that to screen people at the front door of the eMERGE. People who score at a high risk for adverse outcomes will then use the INTRI contact assessment for the emergency department while they're in the eMERGE. If they get admitted to the acute hospital, we'll continue on to use the full INTRI acute care instrument and its care planning protocols throughout the duration of the stay. Our focus for this part of the TVN project is really going to be a feasibility project and a demonstration that this can work, and a study to see, do these data predict things that happen in acute care like we've seen to be true for instruments in other settings. Do they predict outcomes like ALC status or mortality or level of discharge? In subsequent research, we're interested in then starting to do some trials around looking at the quality of outcomes when these instruments are used as designed versus normal practice. So I want to bring you to our early findings. Notice I've capitalized, italicized, and underlined it to say how early these were. I wasn't sure if in a geriatrics-oriented conference you could say embryonic, so I said early. But that's how early these results are. To begin, I want to tell you about a scale that I led some research around 1999-2000 to create called the CHESS scale. The CHESS scale is a fairly simple scale. It looks at changes in ADL and cognitive function just over the last 90 days. Have you gotten worse in ADLs? Have you gotten worse in cognition? Looks at a list of symptoms that tend to be symptoms like weight loss, shortness of breath, about 6 or 7 different symptoms, and does a count of those symptoms. And then it looks at the presence of a rating of end-stage disease. So it's a fairly simple scale, gives you a 0 to 5 score. When we did the original research on it, it turned out to perform pretty well, and I went to my newfound colleagues, and I had only been part of INTRI for about 5 years, and I said, let's call this the INTRI Frailty Index. And bedlam broke out. The geriatricians almost left en masse, said, you can't call that frailty. And I said, well, why not? Well, that's not frailty. Well, what's frailty? I don't know, just ask a geriatrician was the answer I got. And after about 6 hours of arguing, I said, okay, we'll call it something else. And CHESS seemed to be something that works, so it's become the CHESS scale, but I'll always mutter on my breath, it really is a frailty index. But now some of them are also calling it a frailty index. But this is what it looks like in terms of mortality. So this is a paper we just published as part of the National Population Health Study of persons with neurological conditions, where we looked at people with 11 different neurological conditions in 3 different care settings in complex continuing care hospitals, nursing homes, and home care settings. And these are survival curves. The time for follow-up is 180 days. And you can see that in each of these cases, there's nice differentiation in mortality rates by the CHESS score. People with a CHESS score of 5, that's a pretty high mortality rate that you see. There are differences across sector, so it works better in complex continuing care and nursing home settings than in home care. There's a little bit less differentiation there, so maybe there's some other parts to be adding to the mix, but really in each of these care settings, for these people with neurological conditions, it still differentiates. One of the things that surprised me the most in this research is when we broke it down by subtypes. I never thought it was going to do much with ALS, but it actually does differentiate mortality rates even within ALS patients. And then if you turn around to say, well, put it in a survival model to look at hazard rates after you adjust for age and sex and diagnosis and so on, that's what the hazard rates look like in terms of those three different care settings. So we see it's a pretty similar performance of increase in the risk of mortality across those service settings. So that sort of tells you about the tool I want to use to look at this question, but I'll go step back a bit further. Several of you, Duncan and I know Gloria will remember my PhD supervisor, Bill Forbes. And in the mid-1980s, I was just a grad student, and we had the Butterworth series of books on individual and population aging. And Bill wrote the book on institutionalization of the elderly in Canada. When I was a master's student, I still have his signed copy on it. It was interesting when you look at his book. Bill was a statistician by training, but in the entire book there was only one data table that described clinical characteristics of nursing home residents, and I think it was the study Duncan, you and Paul Stoley were involved in Saskatchewan, describing ADL status in a sample of around 700 patients. Well, when the Canadian Journal of Aging did an update on this Butterworth series, Bill had already passed away, and I was given the honor of writing the paper to follow up on his book. And so, the focus became on, how we changed from that time when there were very little data available for long-term care and home care to one where we have an awful lot of data. But as we sort of put together those tables, there's a couple things that kind of struck me as interesting. By this point, we still were in partial rollout in several provinces. This was around 2009 and 10, so we didn't have quite the numbers that we have today. But I have a table in there that looks at discharges within 90 days. What's kind of interesting is there's some variability. So in Ontario long-term care homes, 6% of residents are discharged within 90 days. Saskatchewan, 9%, BC, 3%. So there's some variability there. But we also looked at, well, why were they discharged? And if you look at mortality, well, you've got 90% mortality in Manitoba and British Columbia. So of those people who were discharged, 90% were discharged because they died. But then in Ontario, it was only 38%. And actually, 50% went to hospital, whereas other places, not that many are going to hospital. And that sort of made me think, well, in Ontario homes, is there this process where people in nursing homes start to look frail, and before they die, they get sent to hospitals, where in other provinces they die in hospitals? That was sort of an interesting question to think about. Well, one of the things you want to know is, clinically, are they different populations? So you may have a problem in the back looking at this. So we got the chest scale on the bottom. If you look at chest scores of 3 or more, you get, again, quite a bit of variability. You get about 8% in Ontario nursing homes compared to about 16% in Saskatchewan nursing homes and 24% in Yukon nursing homes. So there are some clinical differences between these jurisdictions that we can measure with something like the chest scale. So that was sort of ruminating in my mind for several years. Along comes TVN and Paul Hébert, and we put in a grant proposal. And in that project, one of the things we wanted to do is look at, what's associated with transitions from nursing homes to hospitals. So now you have, within the first 2 months of our project, some early analyses to look at that issue. And so the basic thing is, this is a 1-year survival curve of discharge to hospital after admission to nursing homes. So the starting point is the day you were admitted to nursing homes, and we're looking at transition rates to hospitals, which is around a 25% transfer rate within 1 year of admission to nursing homes. It's a pretty substantial movement between settings. My previous table was within the 90-day period, but when you go to a 1-year period, now we're talking pretty substantial proportions making that move. If we continue looking at a 1-year follow-up, this is transfer to hospitals from nursing homes at admission to nursing homes, and then looking at time to admission to hospitals. What we see is the rates are pretty comparable for Manitoba and Ontario. Ontario is a little bit lower. British Columbia is hiding behind there somewhere. It doesn't quite show up in this graph, so it must be overlaid with one of those. But then in Newfoundland and in the Yukon, you see a little bit faster rate of transfer to hospitals. None of this controls for clinical characteristics yet, just looking at regional differences. So then, it begs the question of, does the chest score predict transition to hospitals? And the answer is yes, but something weird happens on the way to the hospital. So if we ignore the green line for a moment, these are they're pretty much rank-ordered chest scores. The higher the chest score, the higher the probability of admission to hospital. So one of the things that we've got is a very simple tool that's available right away that probably tells you about risk of hospitalization. In this case, now we're looking at a 90-day period for this analysis. So people with the chest score of 4, about 20% of them are admitted to hospital within 90 days compared to around 5% with a chest score of 0. So a fairly substantial difference there. But this green line here, that's kind of weird, are the highest chest group, the chest score of 5, who kind of dip down and then go flat after that, which is sort of strange. I kept looking at this and then working with my staff to say, okay, where's the coding problem in the data? We've turned it around every possible way we can look at it, and it's not a coding problem. It's probably a reflection of mortality. So if we look at admission to nursing home, for the people with a chest score of 5, half have died within about 2 weeks. By the time we're at a 3-month follow-up, we're down to 15% survivors. So a huge mortality rate for people coming into nursing homes with a chest score of 5, which will result in that really weird pattern of censoring that, the ones who didn't die are probably the ones who had a delirium and other things going on that was rectified and they're stabilized, or something else was going on with them. So what it does say, though, is that if we're going to try to understand hospitalization, we've definitely got to think about mortality as a competing risk, and any kind of modeling or thinking we do about this needs to look at multiple outcomes, not just a single simplistic outcome. Just a couple closing comments. First of all, I think if we look at where we are in the Canadian context, we're in a pretty unique opportunity in terms of the scale of implementation of these instruments to really study frailty, at least in the home care and nursing home settings, but many other sectors as well, with very large data holdings that are already in hand and are growing on a daily basis. And some of these scales that we've got, I mean, we have the chest scale as one measure, but we have about 20 care planning protocols, and there's about 10 other summary measures of things like depression and pain and ADL status and cognition. Those scales and the care planning protocols can very easily be used for targeting purposes within those settings. And so then it becomes interesting of, well, what do we do in a nursing home where we've got somebody that comes in with a chest score of 4? What do we do now? Do we sort of say, okay, what can we do to avoid the hospitalization? That's probably in the person's interest if that's possible. Is there something underlying that person's condition that's causing this instability of their health? A delirium would be an easy thing to think about. Or is now the time to start having advanced care planning discussions to say, okay, you're in pretty tough shape. If I look at people like you, you've got a high risk of going to hospital. What do you want to do in the case that something happens? Do you want to go to hospital or not? It'd be a reasonably easy basis to sort of think about targeting care planning discussions for. And just, the one tantalizing bit here is we saw some small differences, but interesting around regional differences. And it's probably going to be the case that as we dig into this further, that some regional differences are going to be explained by clinical subpopulation differences. This region has more of population X, that one has more of population Y. But probably some of those regional differences are going to be the result of practice pattern differences that can't be explained away by population differences, and really it's likely to be a combination of the both as well as a number of other things, and that's where I think our discussions start to get really interesting. So thank you for your time and attention.